Okay. So, Assalamualaikum and good day to everyone. So, I would like to basically welcome you all for our neuro emergency CME today. So, for those of you who actually this is your first time of joining, we just started doing our neuro emergency CME under neuro emergency special interest group, which is actually not many of us. And we will be discussing mainly regarding neuro emergency related topic. All right. So if you guys have any questions or any discussion that you would like to ask around, you may do so. I can put it inside the chat box, or you can unmute yourself at the end of the presentation. So I think without further ado, I'll just start on my topic today. So I'm going to talk about the story of my small brain. So basically, I think when I say about this, many of you might have had some idea on what is the topic that I'm going to talk about. So basically, why do I think that our cerebellum deserve as much attention as our cerebrum, okay, the big hemisphere, okay, the main one that we normally see in patient that comes to emergency department or get admitted to medical ward or neurology ward perhaps. So a lot of people thought that it is small, it is insignificant, or it does not have as big problem as compared to when you have MCA infarct, for example. Okay, so actually it is equally disabling as well. And basically it can actually cause you more harm because the space at the back of your cerebellum is actually quite limited as compared to your hemispheres of your cerebrum. Okay, so as I've mentioned earlier, in fact, in this area at your cerebellum can get edematous quite easily. So, so this is in a way is not good because it can lead to decompression of the fourth ventricle, and also it can affect your brainstem as well. So if this compression goes further and it basically compress your brainstem, your medulla oblongata, where all of the respiratory center, the one that is actually controlling your blood pressure, heart rate, and so forth is there, it can lead to death. So despite this, it goes unrecognized and misdiagnosed. So because of this, throughout my practice, I've been wondering that I'm not sure whether you have a similar concern as like what I had. But I noticed that when we are examining patient that comes in with cerebellar stroke per se, the one that we have in our mind is, oh, you have to check the dysrhythmic we have to check the fast pointing. So actually, there are many more signs that is actually not being well described, and most of us we do not test the patient gait. You said patient is too weak to walk and so forth. We do not even sit up the patient to see whether this patient has truncal ataxia or not. So these are the things that actually makes me wonder why there are certain patients that come in with a cerebellar stroke has marked dysarthria, for example. They cannot speak well. You know, sometimes you ask them to speak or to say words like Persatuan Peladang-Peladang Pulau Pinang or baby hippopotamus. Some of them, they can't really pronounce it. And you know, this is a clear-cut cerebellar stroke. But most of the patient, okay, I would say the one that come with a typical symptom, maybe about 20 to 30%. But those who come in with only dizziness or vertigo or nausea or maybe tinnitus. So these are the population that we actually miss because we thought that, oh, this is peripheral vertigo and this could be something else. So basically today, I'm gonna just brief through about the what are the different findings in cerebellar stroke that you can actually appreciate based on the location. So therefore, to understand this, we have to understand what are the areas in the cerebella itself that actually responsible for certain clinical manifestation. Okay, so on top of that, I'm also going to brief a little bit. I've just attended this neurological emergencies course, which is under Howard, and I found it a very interesting the way they approach patient to differentiate between central and peripheral vertigo. So I'm going to share this with you as well. Okay, and I'm going to share with you about the importance of early detection of the posterior circulation related findings and manage them accordingly. I don't think so they have a lot of problem in terms of the management of it, but the detection of it is can be tricky at times. Okay, so I would say that throughout my mistakes and also from various teaching CMAs and also courses, I learn and try to develop the skills on my own. Okay, so I'm just going to share that this is one of the um, paper that actually open up my mind on how you basically approach patient with cerebellar infarct. So this paper answered most of my question, that why certain patients they come in with very obvious cerebellar signs such as dysdendrokinesia, arm dysmetria, but certain patients they do not have obvious signs, but they do have something not right with them. Okay, so they do have an infarct. Okay, so for bleed, normally we rarely have a very small bleed localized at certain area. Sometimes they can come with very obvious findings, but the problem is if they have micro infarcts. These are more challenging for us to detect. But why we need to detect that is not maybe even though we may not be thrombolizing them, but it is important to work out on the cause that actually the causative factor of this. Is it microembola? Is it dissection? So that it won't occur again. So the prevention actually depends on how you are able to detect the earlier problem that this patient might had. Okay, so this will be the outline of my presentation today. So I'm going to talk about the function, anatomy of the cerebellum, okay, and its blood supply, which is very important when we talk about cerebral vascular disease. Okay, then I'm going to brief a little bit on the symptoms and signs for cerebellar infarct. Okay, and how do we elicit the central from the peripheral causes of vertigo or dizziness? Okay, and this is something that I think I've learned, a new thing that I've learned this year. And I would like to share with all of you, and hopefully it can help you in managing patient that comes in with a complaint of dizziness or lightheadedness and so forth. And for those of you who have never heard about this, there is a test called HINS test. Okay, but even though I've heard this during when I was doing my masters, but nobody really knows on how, when do we want to perform this test. And it is said that this test, okay, if performed appropriately to the right population, its sensitivity is equivalent to MRI. So what I mean, how good can this be? Yeah, all right. So that's why I'm going to share with you when you're supposed to do it, so that you will be able to elicit the signs, and you will be able to diagnose efficiently central cause of vertigo. And I'm going to talk a little bit on the imaging, okay? Because for me, if we're able to detect a central vertigo, which is related to posterior circulation infarct, the management is quite easy. We refer to the respective team. But in the process of diagnosing it, imaging will get involved as well. So what is the role? What is the sensitivity of CT? What is the sensitivity of MRI? And which one is better? Okay, to a center who has limited imaging, like for me, in Sandakan, we don't have MRI here. So do I have to send the patient all the way to KK just for an MRI? So it doesn't make sense. So how do we go about this? Okay. And I do have a little bit of questions so that you will stay alert throughout this presentation. Okay. It's not to penalize anyone, but it's just that to see whether you understand or not of whatever the content of today's presentation. So we have to look at the function of cerebellum. So why we have this big brain and a small brain, which is our cerebellum. So basically, your cerebrum is the one that plan for movement. Okay, and the cerebellum coordinates movement. Okay, it maintains the balance. It maintains the muscle tone. Okay, it compares the thought and what is actually happening. So it gives you the I would say that it micromanages. If let's say you want to touch something, you want to touch this phone, okay, how much pressure that you should apply to your finger onto the surface to basically make sure that this does not fall off your hand. So that is the function of the cerebellum. So how does this gets coordinated? So we have a lot of tracks running to the our cerebellum, okay, so that we will have this feedback from our sensory, so that the cerebellum can manage it, and at the same time basically proceed with whatever that our brain is planning to do. Okay, so basically it fixes all the problems that she encountered throughout the process. So this will be the very complex regulatory feedback of the cerebellum. Okay, so the cerebellum itself receives somatosensory input from the spinal cord itself. Okay, from the motor cortex, so the cerebral cortex, and also from the vestibular organs. So that's why when you have patient with a peripheral vertigo, your balance goes off as well, because of it's not a problem with the cerebellum, but it's with the vestibular organ, which is your ear. Okay, and all this input basically determines the force, all right, the velocity, how fast you want to reach to an object, okay, the direction itself, okay, and also the range, meaning how far you should stretch your hand. For example, would be stretching at this distance will be appropriate, or you should stretch it a little bit more. So this all actually being feedback through all this input that we have to the cerebellum. Okay, so next I'm going to talk about the functional anatomy. This is something very interesting that I found in the Neurology Secrets 6th edition. It has 3 sagittal division, right, left hemisphere, and vermis. It has 3 transverse decision, the anterior, posterior, and flocculonodular. It has 3 midline nuclei. It has 3 paired cerebral peduncles. It has 3 major cellular layer. It has 3 major input, which is a corticopontine, inferior olivary nuclei, and also from the spinocerebellar pathway. Okay, actually, you don't have to remember all this. It's just a nice to know knowledge, yeah. And because I found it very interesting, it is all being packed into 3. All right. So these are the things that I've mentioned earlier. We have 3 lobes. We have the vermis in the middle. Okay, we have a right and left lobe or hemisphere. We have 3 cerebral peduncles, superior, middle, and also inferior. Okay, and when we look at the sagittal field, or from the sagittal view, we have this anterior lobe, posterior lobe, and also the flocculonodular lobe as well, which is located at the inferior portion of it. Okay. So when we talk about the anatomical part of the cerebellum itself, okay, we have the pica, posterior inferior cerebral artery, which emerges from the vertebral artery over here. Okay, so it gives out a branch. Okay, and you have this. It is further being divided into medial pica and also lateral pica. Okay, and next we have this ICA, anterior inferior cerebral artery. We actually give a branch to your base flocculum. We have mentioned about flocculum just now. Inferior portion, 8 nerve artery. Okay, this is particularly something that you need to be aware of. Why? And I will explain to you after this. So this one, it comes from the basilar artery. And we also have SCA, superior cerebellar artery, which is at the top, at the end of a basilar artery. Okay, we have medial superior cerebral artery, and also the lateral superior cerebral artery as well. Okay, so the how to divide the posterior circulation brain region? Okay, the proximal part starts from the below. Just hold on. Okay, sorry guys, if you guys have just joined, can you mute yourself? Wait, need to find siapa yang tidak mute ini ya. Okay, alright, fine. Okay, so we have this proximal part of the division, okay, which includes a region of ICVA and also the pica, okay, and also we do have this middle region, okay, which mainly the ICA area, okay, and we have the distal part. So it's slightly different from the what you call that. Maybe people would have thought that proximal actually comes from the upper part. It's actually not Not that way, it's the other way around. It comes it from the below. Okay. So just to explain a bit of it. All right. So what are the main, or what is the main symptom of a patient that actually comes in with cerebellar problem? So this is being described as the cardinal symptom or the hallmark symptom, feeling off balance and abnormal gait. But I'm not judging anyone, but we can ask ourselves, how many times do we ask the patient, okay, to basically step off from their bed and ask them to walk, even though they feel better in terms of their dizziness has got much better. So I've actually what I learned something from this paper was before this, this is not something that I do to the patient. And after I've read the paper, I started doing this a lot. And I feel that you can really appreciate if the patient really have balance problem, and you can diagnose and give you the probability whether this patient you're dealing with somebody who has posterior circulation infarct or not. Okay. So the second most common would be dysarthria. Dysarthria mean you can talk. Okay. A lot of time when people say what you call that, patient has slurring of speech. Yeah. So this is a very funny complaint. But when you talk about slurring of speech, you have to divide into three. Slurring of speech can be due to dysarthria, in which patient can talk but they cannot coordinate well. Okay. Or is it dysphonia? They can talk but they sounded sengau. You know how like nasal speech. Okay. And the other one is because of the dysphasia, because of the weakness of your facial nerve, causing that this patient cannot pronounce properly. All right. So this, when you say a patient has slurring of speech, which slurring of speech that you are actually talking about? So it's important to differentiate these three. Okay. Does the patient have problem with the cerebellar area? Or is it because of the patient of palsy that actually making patient difficult to pronounce because of the weakness of the facial nerve itself? Okay. All right. So basically, the sign and symptom of cerebellar infarct or cerebellar problem highly dependent on the area that is affected and its size. Of course, if the area affected is very small, you will have very, very subtle symptom. Okay. And also sign. And might be very difficult to elicit as well. So if the size is bigger, so maybe the sign and symptom of the patient of you being able to elicit the cerebellar sign and symptom is much more easier. So I'm going to talk about Pica territory. As you know, Pica territory is the one that is located the most down part, okay, in which the branch of this artery actually comes from your vertebral artery. Yeah? Okay, so most of these patients, they don't come with slurring of speech, so-called. Okay, you may not be able to see them to speak a very incoherent. Okay, they will be able to say, Pakcik, sila cakap baby hippopotamus or Persatuan Peladang-Peladang Pulau Pinang. They will be able to mention it well to you. And you say, oh, this is not a cerebellar problem. And that is not really right. Okay, because this type of population, they basically comes in with a lot of very vague symptoms, so-called vertigo, imbalance. They may have headache, which is ipsilateral or the same side with the problem. I mean, the cerebellar area that has problem. They may come with nystagmus and get ataxia, and also truncal ataxia for that matter if patient is not able to, if the dizziness is very bad and they are not able to stand up and walk. So if you do not test the patient on a sitting position, on when patient walk in a walking test, you may not be able to elicit. So guys, the thing that I wanted to basically emphasize is it is very true that to complete your neurological examination is by looking at the gait of the patient. Okay, so that is the thing that I would like to share with everyone. Yeah, do not take shortcut, because if you take shortcut, you may miss a few important findings. Then this finding is the one that actually is going to be or to give you the main clue for whatever the diagnosis you are actually going to make. Okay, So basically, if the inferior portion of the cerebral is affected, vestibular input, which is your balance. So we have discussed that vestibular input gives the feedback towards your cerebellum to maintain on how you should basically put your body position at, okay, and also a bit of proprioception, okay. And if isolated medial pica is involved, only vertigo will be present, okay. And nystagmus is prominent, okay. So we have to check nystagmus as well. So basically, wearing upon walking, when you ask the patient to walk, you see which one patient will be able to tell you. From my experience, you can ask the patient, Pachi or Machi, where do you feel that you tend to basically veer to one side? Okay, so the patient will tell you that, I don't know, I just feel that I feel like falling, but it's more towards the right side or more towards the left side. So they would be able to tell you. Okay, and because cerebellar also basically manage your tone, so you may find you will have hypotonia over the ipsilateral limb, the same limb that your cerebellar lobe or hemisphere having the problem. Okay, so commonly, this is caused by emboli, okay, originated from the heart, aorta, or the vertebral arteries over the neck. Okay, again, if it is just a very small infarct, okay, patient not very disabling, most of the time we may not be thrombolizing the patient. Okay, if you are in an area where or in a center where you can thrombolize, but it is very important to basically detect what is the cause of this stroke, because it is important to plan how to prevent it from actually occurring. So that is very significant. Okay, so just to share about the location, yeah. I mean the what are the signs and symptoms that you may get
Ada
if you have a
mutton, mutton
if you have a patient that comes in with this pica territory infarct or stroke, okay, you will have contralateral loss of pain and temperature sensation. Okay, so why does this occur? It is because your spinothalamic tract, okay, it crosses over, okay, at the cerebellar level, it crosses over, that it rises up. Okay, so if you have the problem at this side, the contralateral side will start to have all these abnormalities. Okay, and you can have ipsilateral facial loss of pain and temperature. This is because your fifth is also affected. Okay, and you can have a vagus nerve. So these are, we are talking about if it involves the brainstem area. Okay, because the location of the cerebella and the brainstem is very near to each other. Okay, so that's why if you have an ischemia which extended further to the area of the brainstem, where you have the nuclei of 5, 6, 7, 8, 9, 10, 11, 12, you may have all these problem as well. Okay, so it is called a bulbar palsy, okay, which actually you have a lower motor neuron of these nerves. For example, you have absence of gag reflex, okay, your tongue might be deviated to the ipsilateral side of the lesion, okay, and you may have nystagmus as well. Okay, I will tell you on how do we actually appreciate nystagmus in my next slide. You can have ipsilateral Horner syndrome. Okay, so Horner syndrome, what we normally know or what we do have, even previously, I thought Horner syndrome only occur when you have apical tumor, Pancoast tumor, but that's not the matter. Anything that actually disrupts the sympathetic chain can actually cause you to have Horner syndrome. So in this case, the descending chain of the sympathetic pathway is being affected. So you may have Horner syndrome. Okay, and you can have palatal clonus. Okay, you can just Google or in your YouTube. Palatal clonus is when you ask the patient to open up the mouth, you can see the uvula, and the uvula will be like having what you call that, having a clonus inside it. So that's how you call it, palatal clonus. And of course, patient can have ataxia as well. Okay, so we finished talking about PICA territory related issues. So now we're going to talk about ICA territory. Okay, it can be divided into infarct limited to ICA only, infarct with bilateral ICA involvement, or unilateral ICA with brainstem. Okay, and this is the place where you can have involvement of 8 and 9 nerve palsy. Okay, so traditionally, um, we are being taught, I was being taught, and I also taught in that way, that if you have a patient that come with dizziness, for example, uh, you ask the patient, do you have tinnitus? Do you have hearing loss? So if they say yes, automatically you will shut off your differential diagnosis for central cause of vertigo, and you will say, oh, this is a peripheral cause of vertigo. I need to refer to the ENT team. So what we need to understand here, that is not always the same thing. It does not always work in that way, because if we see, I will show to you, internal auditory artery is actually a branch of ICA. So if you look over here, okay, so this is your basilar artery, okay, it gives a branch to your ICA, and if you track further, this is your labyrinth artery. So you see, it actually gives a branch to your inner part of your ear itself. So if you have ICA related ischemia or infarct, okay, you can have hearing problem as well. So this is not something that we can say confidently that, oh, if you have tinnitus, you will surely have peripheral related vertigo or peripheral related problem. So this is also something that I wanted to share with everyone. Okay, that's not the case at all the time. Okay, so what are the sign and symptom of ICA territory infarction? Okay, again, as I've mentioned, you can have pain and temperature loss contralateral side. You can have hemiparesis if it wants involve the corticospinal tract. Okay, and at the ipsilateral side, if it involves the fifth nerve, you will have loss of pain and temperature over the facial area, which is the same side with the area of the cerebellar region that is being affected. You can have loss of hearing, vertigo, peripheral facial nerve palsy, okay, and cerebral ataxia. So when you have a patient, yeah, that comes into you with lower motor neuron facial nerve palsy, okay, do not just commit that, oh, this is Bell's palsy, okay. You have to really check through, okay. I hated neuro last time. A lot, because I don't understand why you need to check everything, but when you read this, then it makes a lot of sense that you have to check for the presence of any other cranial nerve involvement or motor involvement for you to be able to say that, yes, this is an isolated lower motor neuron 7 nerve palsy. Okay, if you do not check, you may miss that this patient might have some cerebellar problem that comes in with peripheral facial nerve palsy, and you say, oh, this is just a Bell's palsy, and the patient might get another stroke, we actually may taken up that patient's life. Okay, so we have talked about PICA and ICA territory infarct and what are the signs and symptoms. Next, we're going to talk about ACA territory, which is the most distal part. Yeah, okay. So it is easily overlooked if in partial. Okay, patient may not come with severe dizziness. So this will be a bit the differences. The lower it gets, patient complain more about vertigo, dizziness, those kind of imbalances. But as the lesion goes upwards, okay, if the lesion is mainly over the upper part, they do not have so much of vertigo. And this is particularly quite important to understand as well. Okay, so in this population, this is the type of cerebellar so-called sign and symptom that we normally appreciate through our findings, first examination, like you ask the patient to do to flip the hand like this, okay, and you ask patient to do this fast pointing. Okay, these are the things that can be elicited, and if it is positive, it is positive, but not so much if you are dealing with the one, the ICA and also PICA territory. Okay, so dysarthria and dysmetria, intention tremor may occur with rapid improvement. So these are the, I've had a patient that comes in with dysarthria, and also they have intention tremor as well, but after a while it resolves. So there was somebody else who reviewed the patient and said, oh, this is very unlikely to say it is related to cerebellar infarct, cerebellar region problem. So I was thinking to myself, was my diagnosis was wrong at first place, or what actually occur in this patient? So as you can have anterior circulation TIA, for example, you can also have posterior circulation TIA. Okay, so it works both way. So sometimes in this ACA territory, you may have all these symptoms, but it disappears after that. So you might be dealing with transient ischemic attack for that matter. So this will be the SCA syndrome. Okay, is basically just to tell you that this is a huge infarct. Okay, when it happens at the lateral pontine tegmentum, superior portion of the cerebra and part of the midbrain, and these are the sign and symptom that the patient may have. Okay, so basically, patient will have loss of pain and temperature over the face, arm. Okay, again, this explains about the spinal thalamic tract, and you may have the fourth nerve palsy. Okay, you may have limb ataxia at the ipsilateral and also Horner syndrome. But again, it does not matter. You don't have to basically memorize each one of it. As long as you understand, okay, what to look for, why are certain symptoms are more prominent, why are certain symptoms may be difficult to be elicited, that should be fine. And most importantly is to do a thorough neurological examination so that you do not miss any sinister causes that is causing a patient to have such symptoms. Okay. So I'm just going to talk a little bit on how serious a pseudotumoral cerebral infarct can be. Okay, so this is actually a condition that occurs after a full PICA territory infarct, which may occur also in SCA. So you will have all these raised ICP so-called symptom. You have increased headache, vomiting, depressed GCS. So this is the condition. If the patient is presented to us for the first time, then yes, there's nothing much you can do. But if let's say the patient has presented to you few times and you discharge the patient because you thought this is not really related to the central vertigo, okay, or central cause of problem, then if the patient presented to you in this kind of condition, it is very unfortunate. Yeah. So people say that the eyes is window to the soul, but it is also an eye to your cerebellar as well. So in this kind of situation, okay, you may have gaze paresis, okay, because this is basically when you have a brainstem involvement. So basically, when you look to the right or you look to the left, your sixth nerve and your medial rectus nerve, which is being innervated by your third nerve, also took place. They have to basically work together or bekerja sama. So if any of the problem occurs at the PPRF, paramedian pontine reticular formation, okay, and your MLF, you will have this conjugate gaze paresis. So it's not the third nerve which has problem or the sixth nerve which has problem. It is because of the coordination is not good, and they call it this internuclear ophthalmoplegia. Okay, so I would like to show to you about ocular bulbing, and this is a very interesting to see and appreciate it.
This patient was still in the intensive care unit. He has had a pontine hemorrhage causing total paralysis of horizontal gaze to the right and left. You see here ocular bobbing with a fast phase down and a slower phase up. These eye movements continue in sleep and under closed eyelids. This type of ocular bobbing is reliable for localization to the pons. It can occur with cerebellar lesions that cause secondary compression of the pons.
Okay, so if you have a patient that comes with this ocular bulbing, okay, it is quite suggestive that this patient has a posterior circulation lesion. I wouldn't say it is infarct or bleed, but it suggests to you that that something is not right with the cerebrum and also the brainstem. Okay. So this will be a picture or an MRI, or CT, both actually, CT and MRI of a patient with pseudo tumoral infarct or lesion. Okay, as you can see, there's a huge chunk of the brain which is being affected. Yeah. So basically, this is not good and has a poor prognosis later on. Okay, so I'm done with talking about the anatomy and what are the signs and symptoms that may occur if you have a cerebral lesion. I'm just gonna talk something which is also related to it, which is about vertigo. Okay, I'm sure throughout your practice, especially if you're working in the emergency department, whether you are in district or in a tertiary care, okay, um, a lot of people will come with this. And I used to hate patient who comes with this kind of problem because I do not know on how should I approach them. And even if I ask them dozens of questions, it does not really help in terms of my diagnosis. Okay, so it is very true because it has been they has done a study and saying that asking in detail a patient symptom, what do you mean by dizziness? Do you feel like the ceiling is spinning, or do you feel like you want to fall, or you feel like headedness? Does your head feels very heavy to one side or the other side? Has low clinical predictability. And no wonder I was not able to come to a diagnosis. It makes a lot of sense. Okay. So why it has low clinical predictability? So some people might say it is very important to differentiate true vertigo from non-true vertigo. So maybe the approach is not wrong. But again, how about in terms of the clinical predictability? It does not really tell us that this is central or this is peripheral. Okay, so when we are doing our practice, in especially in the emergency department or when you are in clinic, the number one thing that you really want to rule out is, am I dealing with any sinister cause that may warrant this patient to get further treatment and admission? So that is the number one that you want to basically reach upon. So apparently, if you ask the patient, okay, for example, yeah, you ask a pakcik, pakcik, do you feel a spinning sensation? And at one point of time, the pakcik may answer, yes, I do feel that something is spinning. But if let's say you ask the same pakcik, 10 minutes later, the answer might change. And this has been proven from a clinical study. So because of this, a lot of experts, okay, deem that asking the patient on how do you describe your vertigo or your dizziness, your lightheadedness is not really useful. But instead, we should approach dizziness, yeah, as how we approach patient with chest pain. So we do ask the patient about the duration, what are the associated symptoms, and then we ask whether the patient has any other issues in terms of working instability and so forth. So that is how basically the new paradigm in approaching patient with vertigo or dizziness or anything which is related to it should be, instead of asking and clarifying, what do you mean by vertigo itself? Okay. So this would be the new algorithm which was being suggested, yeah, by Prof. Jonathan Edlow. Okay, he's an emergency physician in Massachusetts Medical Center in Boston. So he suggested that this should be the new approach. Okay, so you should ask the patient, when your patient comes with vertigo or dizziness, you should ask them what are the other associated symptoms. Do you have difficulty in basically walking? Do you have difficulty in basically chewing and also swallowing things? Because if they do have, then it may suggest that, oh, this is not just related to cerebellar itself, but may have some brainstem involvement. And you should ask the patient the timing and the trigger as well. So when does it happen? Okay, is there any obvious trigger or not? Okay, so why trigger is important? Because if the patient say that, I had it yesterday, but I do not have it now, there is no point of basically examining the patient using a hint test, because the person does not have the symptom now. But instead, the clinical history makes the diagnosis more feasible. Okay, and when you're examining the patient, you also have to look for the exam signs and testing to confirm the diagnosis. So I will explain to you what do I mean by this. So when you are examining or taking history of the patient, these are the three things that you need to divide the patient into. Okay. So when you are taking the history, if the patient is still having the symptom, you are probably basically handling the patient with acute vestibular syndrome. Okay, so if let's say the patient said, oh, my dizziness started yesterday, is still very bad until today, I vomited a few times and the dizziness still continue until now. Okay, so this is the type of patient that has acute vestibular syndrome. Okay, so why it is very important for us to basically classify them into these three different category, because the differential diagnosis for the central cause and also the peripheral cause for each sector is different. For example, if you have acute vestibular syndrome, okay, if the patient comes in saying that, oh yeah, I do feel dizziness until now, it's still very bad. I have few episodes of vomiting, not able to walk well. So as for the peripheral cause, okay, you can have vestibular neuritis, which is also very common, especially after a viral infection. But it can also, if you proceed with examination, uh, this patient also may have a probability of patient having posterior circulation infarct. Whereas for spontaneous episodic vestibular syndrome, okay, for the central cause of this episodic vestibular syndrome would be, for example, multiple sclerosis, yeah, TIA of the posterior circulation. But as when we talk about peripheral or non-central cause related, okay, it can be due to orthostatic hypotension. So that's why it is important to see that which one does your patient falls into. Okay. Whereas for triggered episodic, basically patient will complain that when I turn my head to certain position, okay, I will have this dizziness. So it is quite clear that probably, okay, this patient might have BPPV. There are also some other diagnoses that should be considered, but the most common one will be BPPV. So I've mentioned that you have to basically divide this patient into three category when the patient complain of dizziness. Yeah. So this is the ATAS diagnostic approach in acutely dizzy patient. So as we all know, dizziness is a very non-specific complaint. Patient can come because of their hypoglycemia. Patient can come because they are having heart problem. Okay, bradycardic due to inferior MI, for example. Okay, they may have hypovolemic shock because they have been vomiting due to acute dyspepsia. So it is being suggested that, okay, if the history and examination suggests a non-neurologic medical cause, okay, you can perform this to the patient as part of the screening. Okay, it won't take you longer, maybe about 30 seconds. Okay, you just test the pathologic nystagmus, okay, any arm dysmetria, dysradiculokinesia, and truncal ataxia, where the patient is able to sit up. Okay, but if there is nothing positive here, then you can evaluate and treat presumed diagnosis or diagnosis. Okay, meaning that if you feel that this patient having dizziness and you check there is no sign and symptom on these three things, then you can say, okay, then treat whatever problem that patient may have, such as a hypovolemic shock and so forth. But if the answer is yes, or the history and exam suggests non-neurologic history and exam suggests a neurologic general medical cause, okay, and the dizziness has been continuously present and persists at the time of evaluation, okay, then you can divide into the stream. So you have to ask yourself, is the dizziness still present at that particular time when you are seeing the patient? If yes, you use physical examination to distinguish vestibular neuritis from stroke. If the dizziness is no longer there, okay, maybe the patient said, yeah, yesterday I had some dizziness, but today it's already gone. I'm just a bit worried of what is wrong with me. Then you use history to distinguish vestibular migraine from TIA. Okay, it's not just vestibular migraine. They have some other diagnoses as well. Okay, so is the dizziness triggerable? If the answer is yes, then you use physical exam, okay, to distinguish BPPV from CPP and orthostatic hypertension. Okay, so these are the things that actually are useful, in my opinion, for you to approach patient with dizziness. But I would say that most of the time, patient come to the emergency department because of this, yeah, persistent dizziness. Because I'm not sure about in other places, but in Sabah, it's very difficult for the patient to come to the emergency unless if it is they are very ill. Okay, so for that matter, I would say that most of the patients that I see in my emergency department are the patient that has acute vestibular syndrome. Okay, so we're going to talk about HINS test. Okay, HINS stands for head impulse, N stands for nystagmus, and skew deviation. So this test was actually being developed by neuro-ophthalmologists, and they said that if this test is being performed appropriately, it is almost equivalent to MRI sensitivity. Okay, so I'm going to talk about this hints test in vertigo. All right. So we just have a look. This video is a bit long. Oh, sorry.
The HINTS exam in vertigo. This video is about who to perform the HINTS exam on, how to perform it, how to interpret the findings. The voice is not that clear. Do you want to share the
Sorry?
voice? The voice.
Sorry, Ashraf, apa dia?
The voiceover is not clear. If not, then
Oh, okay.
maybe
Can
you
we just?
comment.
Oh, okay. All right. Sekejap ya. Wait. Okay. In this hints test, yeah, they are going to perform 3 tests, which is the head impulse, okay, the nystagmus, and also the skew deviation. Okay, so basically in the head impulse, they're going to shake the patient head right and left in a very rapid movement, and they're going to see whether there is any corrective saccade or not. If there is corrective saccade, okay, the patient is suggestive for peripheral kind of vertigo, peripheral causes of vertigo. If there is no corrective saccade, then it is more suggestive of central vertigo. Next, we're going to talk about how do you see the nystagmus. If you see a nystagmus which is directional changing, okay, when you check to the left, it's going to the right, and you check to the right, it's going to the left. It may be suggestive for the central cause. And then lastly, you're going to talk about on how to elicit skew deviation. Okay, so basically you close one eye, okay, and you change the eye alternately. And basically, if you see the eye is vertically moving upwards, okay, then it is considered as positive, and any of these would suggest you, if it is positive, any of this would suggest you that you are dealing with a central cause of vertigo. So you just look on how they perform the test.
Now, when you ask them to look laterally, you might fixate on fingers or something on the wall. So in order to take away fixation, which can suppress the nystagmus and vestibulosis, you can place a piece of paper between their head and the wall and ask them to look at the walls. That takes away fixation. You might see nystagmus, which you can see. In this patient, cerebellar neuritis, observe this nystagmus. Here it is again. When it looks to the left, this nystagmus increases, it's left beating, and there's a rotatory component towards the left. It increases when it looks to the left, it's towards the component. When it looks to the right, it lessens, but the fast component is still towards the left. So it's unidirectional nystagmus, hasn't changed direction, and its exam is compare that to this lady. When she looks to the right, she has small horizontal nystagmus, fast component to the right. So she'll click twice just to see the little white word beating nystagmus. And then when she moves more central and to the left, you can definitely see that her nystagmus is now beating towards the left. So she has direction changing nystagmus, bidirectional nystagmus. That's worrisome. The next component of the exam is the test of skew. We observe this by doing the cover-uncover test. You simply take your hand, place it over the patient's eye, and cover the other eye, and observe if there's any vertical movement of the eye when it's uncovered. In this patient, observe how when I first take away my hand from his right eye, that the right eye will go really and up. And when I take my hand away from the left eye, it's a little less as we go along, but there's definitely some vertical skew deviation, which is worrisome. It's upward, medially, downward, medially. So this normal vertical skew deviation is worrisome. The head impulse test is, we have abnormal if you have vestibuloneuritis. Head impulse test is looking to see if you have a nerve problem. Have a nerve problem, probably don't have a brain problem. So it's a little counterintuitive that an abnormal finding is a good finding. In order to perform the head impulse test, hold onto their skull, have them look at your nose or and then move the head back and forth until you're sure that the neck muscles are relaxed. And then, in a random fashion, move their head briskly to the midline, but maybe 20 degrees out. What you're looking for is an abnormal catch-up subtract, which I'll demonstrate shortly after this normal here. So again, holding onto the skull, the head slowly to relax them, and then moving their head briskly to the center and looking for any abnormal movements. Your eyes remain completely fixed on the camera, and that's normal thing. Which in a normal person is good. If you had acute vertigo lasting hours and days in nystagmus, here is an abnormal head impulse test. Notice how this man initially, you can see some nystagmus when he looks to the left beating nystagmus. Then when his head is turned to the right, you see the catch-up subtract. This is normal, that one. Next one will be the catch-up subtract. You see how there's a larger movement of the eye from the right to the back to the midline. That's an abnormal head impulse test, which is reassuring in the NeuroEM SIG because you're showing that he has a nerve problem, probably doesn't have a brain. Here's another one. Again, his head is moved to the left this time, so to the right. Then you have an abnormal head impulse. This is actually normal. This is nystagmus. One more time to the right, which is abnormal. There's a catch-up subtract. He almost did it while his head was being turned, but it was not normal. So that's reassuring things to examine because it has an abnormal head impulse test. This lady we saw earlier with infection changing nystagmus, she has a rock-solid head impulse test, which is worrisome because she has acute vertigo and nystagmus. We can't find a nerve problem, so she probably has a brain problem.
Okay, just to share about the tips on how you do this HINS exam. Of course, I took quite some time for me to understand and develop the skill as well. You do not do this HINS test if the patient has no nystagmus. Okay, so you only do it if the patient has nystagmus, so that you will add on more to the clinical probability in the diagnosis itself. Okay, so in terms of the tips in performing, okay, skew deviation, if let's say you're closing this eye, okay, and you are alternating your hand to the other side, you can focus only to this eye. So do not look right and left, right and left. Okay, so it will make things a bit difficult to appreciate if there is any skew deviation. So instead, you look at one eye, and when you occlude the other eye, then you can see whether there is any movement. Sometimes the movement is very, very subtle. So you really have to be vigilant with it. It takes quite some time for you to be able to appreciate it. Okay, so you just have to look at one eye. Some experts also suggested that you do this slow-mo camera. Okay, so I tried slow-mo camera. It does not work for me. So I think if I just fixate my eye to one eye of the patient, all right, and when I'm satisfied, I can change it to the other eye. I think it works well for me. So I'm not sure whether it works for you or not, but I'm just sharing the tips. And as for the the head impulse test itself, it does not matter how fast you want to basically pull the patient's head to. You just have to have a very rapid movement, even a very not slow, minimal range of movement, 10 to 20 degrees. As long as you do it rapidly, that should be good enough. So you don't have to rotate the whole of the patient head up to here, for example, like 45 degrees altogether. But you just have to do like just a little bit. But the key to this diagnosis or in eliciting the sign is basically doing a rapid movement of the eye so that you may be able to elicit the corrective saccade of the patient if it is present. Okay, so these are the things that it is suggested, okay, by Prof. Edlo. You have to ask yourself if there's any central pattern of nystagmus. Okay, then you can proceed to do skew deviation test. All right, any of these, okay, basically will suggest that you're actually dealing with a central cause of vertigo. Okay, and of course, even though sometimes your examination is already very suggestive of central vertigo or suggestive of peripheral vertigo, I would definitely ask the patient to sit or at least walk unassisted. Okay, because I think in medicine, after we have been practicing for quite some time, there is never no to anything which is atypical. Yeah? So you will have somebody who has negative on this and this finding, but on the other side, they have a positive finding. So I would still ask patient to do a complete to complete my physical examination. I will ask the patient to walk, yeah, or sit at least. Okay, so this is how basically yeah, that I've mentioned. If the patient has no nystagmus, okay, it will make the heat interpretation a bit more problematic, and it makes the diagnosis of vestibulonephritis or labyrinthitis very unlikely. Okay, some call it acute imbalance syndrome. Okay, whatever it is not reassuring. You can't really say this is definitely central or this is definitely peripheral. Okay, the scary part of it is this is half of cerebellar stroke patient have no nystagmus. So again, it depends on where the stroke actually occurs. Okay, so in a recent retrospective study, 33% with acute vestibular syndrome with no nystagmus had CNS causes. So again, if you want to perform Hins test, you have to make sure that this patient has directional changing nystagmus, or at least has a nystagmus, so that you will be able to interpret it. So if you do not have it, then you have to rely on the other physical examinations finding in terms of diagnosing the patient with probable central cause of vertigo. Okay, so let us have a look on the what are the signs, exam signs that actually may suggest this patient has central cause of vertigo. So as you can see, none of these signs basically has 100% sensitivity. All right. So I think everyone agrees with this. So how to increase the sensitivity? So I give you an example. If you're examining patient with shock, do you say that feeble pulse is the only thing that actually can diagnose patient is in shock? I'm pretty sure that you will say no. You have to combine with several other findings, such as looking at your CRT, all right, looking at the peripheries, whether it is coolish or warm. So, and you have to look at the blood pressure. So it is a cumulative assessment for you to come to a diagnosis or a syndrome that, okay, probably this patient has this and these are my plan. So it goes the same for patient with a central cause of vertigo. So if the patient has horizontal or unidirectional, it is suggestive for peripheral, whether if it is central, horizontal, directional changing. There are about 50% that this patient might have central cause. Okay, how about skew deviation? Not really good sensitivity. Okay, if the head impulse test suggestive of corrective saccade, then it may be suggestive of peripheral, but if it is absent, it can go up to 85% of sensitivity. And if there is any CNS sign, about 65% it may maybe suggestive of central cause. And if the patient is unable to sit or walk unassisted, about 65%. So how do we increase this sensitivity up to almost perhaps 90%, so that we are able to refer to the appropriate department and make our diagnosis? I would say that it is a cumulative assessment. You have to look at the patient, at the history, and proceed with the appropriate examination. So I just wanted to introduce that, not reintroduce, just to inform, maybe perhaps, or emphasize that a lot of us do not, because in emergency department kan, I do understand. I used to be that one of that person as well. We like to just cut short our history, and we would like to see any other patients as fast as possible, and we do not test the patient gait. So why gait is very important. Okay, so as you can see, in a patient that comes in with, for example, vestibular vulneritis, perhaps, okay, not many of them will have very bad ataxial grading. So this is how they grade 0, 1, 2, 3. Okay, so as you can see here, 0 is normal, 3 falls with upright posture. So if the severe it gets, it is more suggestive of the central cause instead of the peripheral cause. But of course, if the patient comes in very dizzy, you may give some medication, but you need to test them. Okay, so as you can see, in a patient that has stroke, yeah, the probability patient has gait problem is higher compared to those who has just maybe a vestibular neuritis for that matter. So again, to myself, okay, and also to the medical officers who are listening through, please test your patients gait. Okay, even though you might need to do it later, it's okay, but you need to test before you can say that I can safely discharge this patient or refer to ENT without have to worry about probability of this patient might have posterior circulation infarct. Okay, so we talk a little bit about imaging. Okay, um, what I was being told and what I've learned from the Prof. Edlo I would say that actually your physical examination outweigh your imaging. Okay, why? Because CT imaging, okay, most of us have CT in our center, yeah, has poor sensitivity for posterior circulation infarct. Yes, it does rule out bleed. Maybe you want to start aspirin and so forth, but it does not locate you. So most of the time when I ask my MOs or my housemans, they will say that, oh, I can only see multifocal infarct. Yeah, but that's not the reason why we do CT. Okay, the reason why we do CT, we want to rule out bleed so that we can, in a way, start patient on aspirin, or perhaps start with a thrombolytic therapy if in a center with a thrombolysis is being offered. But we have to understand that you cannot say, boss, I don't see any hypodensity at the cerebellar. You may not see, or you will never see, because the sensitivity is very poor. Okay, so how about MRI? Okay, so MRI again has false negative as well, so about like maybe 20%, and some of the finding it can be delayed up to 48 hours. So again, what will be the most reliable finding or the most reliable way of diagnosing patient with posterior circulation infarct? I would say again, it is your clinical examination. So again, in anterior circulation, maybe it is quite easy, yeah, for you to basically see whether there is infarct or not. But that's not the case in posterior circulation. I do admit it is more challenging, but it is not impossible if we brush up our clinical skills. Yeah, I also learned throughout many mistakes, and also things that I've had. So I think it is time for us to basically appreciate. Now we are hoping so much on the imaging that we've forgotten our physical examination actually has higher attribute towards the diagnosis of posterior circulation infarct itself. All right. Wait. Okay, so in summary, okay, the recognition of posterior circulation infarct, especially the cerebral infarct, is equally as important as the interior circulation. Okay, so I know that the stroke management has grown up in the region, many regions of Malaysia, but I would say that the challenge in diagnosing posterior circulation infarct still remains. Yeah, okay. And I would say that at test approach, if you are okay with this, you may use it. Maybe you have some other approach which is okay and totally fine. I'm just sharing with you because I think that this really works for me. Okay, and we have to remember that hint stance is one of the useful adjunct. Okay, if you are not able to elicit it, it doesn't mean that it is not there. So you have to rely on other clinical findings. Okay, and then please remember, okay, again that clinical examination outperform your imaging results. Okay, all right. So I think I have few questions. Maybe we can have a bit of session lah. The question not very difficult. Okay, so we can put it inside the chat box. All right. Below are the true statements regarding cerebellar infarct, except A. Ocular bulbing is seen in pseudotumoral cerebellar infarct. In superior cerebellar artery infarct, vomiting and dizziness symptom appears to be less severe. Okay, C, absence of corrective saccade in Hind's test indicates benign cause of vertigo. Okay, now D, tinnitus is one of the sign of ICA territory infarct due to its supply to the internal auditory vessel. And E, this atria is more prominent in SCA territory infarction. So which one do you think the answer is? So maybe we can put inside the chat box. Just try to basically have everyone to answer it. You can just type whether it is A, B, tembak also no problem. Okay, Bila say is D. Some say it's C. Okay. C. Alright. C. Alright. Okay, we'll stop here. Alright, so the answer would be it is C, yeah? Okay, A, B, C, D. Okay. Alright. So below are the true statements. Yes, ocular bobbing is seen in studio tumoral cerebellar infarct. Yes. Okay. In SCA infarct, vomiting in dizziness appears to be less severe. It may occur, but it is a bit less. Okay, as compared to pica or ICA. All right. And then tinnitus is one of the sign of ICA territory infarct. So just now we have seen that actually ICA is a branch from your basilar artery and it give further branch to your internal auditory vessel. Okay, and these are more prominent in SCA territory infarct and absence of corrective saccade in Hind's test. So absence of corrective saccade in Hind's test basically indicates that you are dealing with the central vertigo. It may be suggestive of that. Okay. So I think we have another second question, Kani. Just hold on. Oh, okay. So this will be the answer. Okay, we move on to the second one. Okay, below are true regarding dizziness, except, okay, so A, CT scan has poor sensitivity in the detection of posterior circulation. B, clinical examination performs better than any imaging available. C, if clinical examination suggestive of abnormalities, one should perform a CT scan throughout infarction. Hind's test has its value when it is performed in a patient with nystagmus, and gait severity in central cause is more severe than those in peripheral cause. Okay, what do you think about this? Which one is the answer? Can put inside the chat box. Okay. C. Alright. Oh ya, yeah, it's labyrinth artery ya. Okay, tapi ada nama lain juga kan? Bukan kah? Ada nama lain juga kan? Okay. Alright, okay, anyone want to answer this? C. Alright, good. Okay, can I have one more answer before I conclude it? Okay, great. I think we end it here. Okay, so you are very correct. You don't do, I think this one, perhaps we have a neurologist, Dr. Ashraf, around. We don't do CT to see that is an infarct or not. The infarct is a clinical diagnosis, yeah? Infarct is a clinical diagnosis. You do it throughout bleed, okay? Or is there any other things lah, macam SOL ke apa ke, to rule out that that is why you do CT. You don't say that from the CT is multifocal infarct, that is just a CT finding. So you have to basically decide that this is a stroke, that you do accept, okay, if you don't see anything abnormalities from the CT, doesn't mean it's not there. Okay, but what you can say is, okay, it is safe for me to start with thrombolytic therapy, or it is safe for me to basically start the patient on aspirin. Okay, all right, I have one more question to ask before I open the floor for further discussion. Perhaps we can have good input from everyone. Yang ini, testing you all punya, what you call that, attention. How many stars do you think there were in my slides? Okay, can we just tembak sahaja? Because I think nobody counted the stars, yeah. This one just for I cannot say more than one, yeah. Of course, definitely it was more than one. Okay, 6, 8, 12. Wow, Adiba 12. You are quite near to that. Okay, so what are these stars basically indicates? It means that these are the slides which is important lah. That's all. 10. Okay, come we have a look, yeah. Alright. Okay, there are actually berapa ni? Actually 16. Okay, 16 slides lah yang important. Okay, so I hope I'm not the what you call that, the main expert for this field, but I feel that it is important, yeah, for us to work together with other teams. Okay, with the neurology, with the medical, to basically, because we are the first person, okay, the EPs, the medical officers, yeah, you are the first person who is actually seeing the patient. So if we do not refer them for further management, further workout, so pity the patient. So I feel that this is just my sharing on how basically we can improve ourselves to basically being able to detect the abnormalities that you may find in patient with posterior circulation infarct. so that the outcome for this population or the people that actually suffers from this problem can be improved. Okay, so with that, I thank you. I would like to open to the floor to ask question, and also for the input from other EPs and also our neurology, Dr. Ashraf, for being kind enough to join our session today.
Yeah, Dr. Nasrina, thank you. Call very comprehensive. If I may to share, basically in neurology, usually if you are with us in UCAM, we try to avoid, as mentioned by Dr. Nasrina just now, it's actually quite common that we try to avoid dizziness statement as because of it's very non-specific. Dizziness, pening kepala, kan pening kepala sama lah, very non-specific. So what I learned from the Maastricht neurology textbook, we divide it to four. Number one is basically vertigo, and just now the Nasrina share a call about the tips and tricks with peripheral versus central. So that then you divide to all the just now acute, whether it's intermittent, yeah, something like that. And then the number two is basically throbbing headache. So throbbing headache, and throbbing headache also will have another chapter on its own, whether it's chronic, whether it's acute, whether it's progressive. Yeah, some will use SNOOP, sudden onset, thunderclap, the SNOOP, SNOOP mnemonic, and postural headache. Postural headache, you feel lightheadedness. So that's the number three. So it can be autonomic disturbance. It can be early sign of postural hypertension, shock. Yeah. And if didn't fulfill all the criteria, then maybe it's not unspecified. So unspecified. So that will be a bit called easier for you to communicate to one specialty to the others. For vertigo, sometimes it's called when we say that the room is spinning, it's vertigo. But when somebody is spinning, the subject feel the patient say they are spinning. It's not vertigo. That's basically not this wrong. It's basically both are vertigo. And vertigo can be as simple as feeling that you are on the boat. Dr. Nasrina selalu pergi diving kan. So basically, you rasa macam you ada atas boat tapi you tak atas boat. So that's also vertigo. As simple as that. So called otherwise, hinge test, everything is actually one of the tips and tricks. But obviously, again and again, because we are talking with clinicians here, emergency physician, likewise in internal medicine and neurology, a good history and examination will be the trick to diagnose this thing. But yeah, so I think as mentioned again and again, neurology is basically not that difficult. It's actually more about you understand it by heart. There's a lot of ways. So basically, there's a lot of called tips and tricks as what being shared just now. The thing is with understanding of the anatomy just now, you started with the artery just now, right? But to share with you artery anatomy, Allah subhanahu wa ta'ala called God help us with lots of variation. We have varieties of called variation. Lots of called syndrome. We have Wallenberg syndrome. We have for posterior circulation, everything, right? But the variation that we have is subhanallah, very, very, very different. So it's actually banyak sangat. And bila you understand like artery just now, I'm interested more with the artery variation, then maybe then you'll be a bit more accurate. Then go back to your history and examination. But unfortunately, not everyone will have access to CTA. CTA, everything, skills with the CTA. So those things. Maybe we open to question first, and I share if a very short one, if possible, about the usual way of we also teach about the vertical gaze and the horizontal gaze connection in normal situation.
Yeah, thank you very much, Ashraf. It's pretty interesting, because I think because I'm talking basically from the emergency point of perspective. So for us, for Dr. Ashraf, dia punya interesting dia adalah dia nak locate kat mana artery. So that is his passion. For me, my passion is as long as I can diagnose central vertigo without missing it, I'm very happy already. Yeah. So we have different, but of course, he cannot be inside my place. I cannot be inside his place because we have different roles to play. Okay. So that is his expertise. Our expertise is basically to treat if this is not a central vertigo for that matter, to whom shall be referred. So these are the things that actually different people will play different role. That's why again, I've emphasized that you have to basically able to detect if you are the frontliner like us, okay, and you have to be able to detect, because if you miss it, the sinister cause, then maybe it will be detrimental for the patient. Okay, but of course, if you're interested, you really love neurology, which I wish I had that patient when I was medical student, okay, like Dr. Ashraf, but unfortunately I was unable lah to develop the passion so much. Baru sekarang ni baru nak belajar sikit-sikit, okay. So by all means, please go all out, because I think neuro is very interesting, because dia tak ada macam if you understand it, you will be able to basically solve the thing that you are looking for. Okay, so do we have further questions? Cuma one thing, Ashraf, I actually tried to look for. I came across that there is a score for this posterior circulation TIA. But in anterior circulation, we have A, B, C, D to score. But how about in posterior circulation TIA? Is there any score? Macam ada terbaca, but I'm not sure about it. Can you enlighten us with it?
I'm not aware of the posterior circulation TIA score. I think yeah, we still use the same TIA scoring, which is the ABCD2 score. Yeah, if I may share a bit, ABCD2 score is to predict the likelihood of having another stroke within 48 hours. It is not a score to triage patient for admission. So basically, if they are low, then you discharge them. If they are high, then you keep them. So it's actually not as such. And that's the thing, which is usually called the wrong thing that I have seen. ABCD2 score, they've been used before. So posterior circulation, to share with you, yeah, it can, most of the time, unfortunately, posterior circulation stroke can lead to a very bad outcome. However, even with neurology, internal medicine, I hope similarly with the emergency department, yeah, it is it will be a fatal outcome, but it is difficult to be diagnosed at times. Don't be too critical and marah-marah to your junior when they miss it. But in fact, you look back in to your training. For example, now you are discussing about it. That's good. So we in this part of the world, without a proper training and proper tools for diagnosis, then very difficult for you to really 100% not to miss it. Very, very difficult. So that's what, even recently our neurology fellow also miss it. Yeah, obviously for me with all the things that we have, then I told him that yeah, it's too obvious and why I didn't pick up the phone. But again, I will not be so critical and then marah-marah, scolding anything. Okay, obviously the outcome is death if you miss. Yeah. So yeah, ABCD2 score, I think you just continue with that. And posterior circulation difficult, and posterior circulation is still not established. In fact, the recent study, the outcome is bad.
I see. Yeah, I think it's very challenging. Any input from anyone else that want to ask question? Dr. Ashraf, you want to share about something, kan? Am I right? You want to share about some?
So I share a quick one.
Yeah, can. Wait, yeah. I have. Are you going to show slides?
Can I use called the? I can share screen, but I use the whiteboard. Yeah.
Oh, you want to use the whiteboard? Okay. Yeah. All right. Okay, can.
Okay. Can, yeah? Okay.
Yeah.
Oh, belum lagi.
Kejap. Wait. I think I have to make you the what you
Co-host,
call that, the host. Alamak.
co-host. You can co-host me.